implementation, we do have two customers here. One is the patient, and the other one is the practicing clinician. Our goal is to be able to do something that makes the right thing to do the easiest thing for both of them to do. Because we'll share that story with you a little bit later, oftentimes our docs and our clinicians know what to do. Again, one of you mentioned a story, and I think it's you, that mentioned that sometimes we prescribe the right medications, but it's very disheartening that half the patients, if not more, don't take it. The question is why, and we'll go through a little bit about that also in our implementation stories. This part, the top line over here, really captures the view about how we see chronic conditions and chronic disease. It's not a disease, it's not a scan, it's not a lab test. Really, when a patient has chronic conditions, it is about a long-term relationship because, in general, your diabetes is not going to go away. Your hypertension is not going to really go away. Your hyperlipidemia is not going to really go away. We're here with you in the long haul. And depending on where you are in your care journey, your needs and the way we need to engage you have to vary about that. So we look at this, treating these conditions is a relationship building one, and that is part of the approach that we take of how we try to impact patients with these conditions. So along that, I think the comments around the roundtable really illustrates this point as well. Now, I think many of you are familiar with that triangle diagram where the top 1% of the patient with the most acute conditions consume 20% of resources, and then the lower down the pyramid, the lower disease burden you have, the less resources you need. We actually like to use this framework over here because, again, because the condition the patient has is a long-term relationship journey. So on the blue side of the diagram is that everybody with a chronic condition starts with before you have it. That's a prevention part. So our job from a population health standpoint is to do well in screening the patients, doing health risk assessments, to know who is the at-risk ones, so that we can engage them early on before they have the condition, or worse off, before they have the event, of which at that point you're only doing secondary prevention over there. Then as they journey along, some of the patients that have preconditions may have the chronic condition, pre-diabetes become diabetes, pre-hypertension becomes hypertension, etc. How you intervene them, how you deal with them, and where they are in their life also requires adjustments in how you do so. The red side of it is the world that the whole healthcare system currently is built upon. The patients that have all the disease burden that we do a lot of interventions on, they come into the hospital a lot. By the time we get there, from a population health perspective, it's too late. The cost, the $1 trillion costs have been incurred already, and then our current climate tends to incentivize work in the red section of that. And we're trying in this world to drive things down to the blue section of that, and how might we be able to do so and be successful at that. So, the previous slide talked about it from a population disease journey perspective. A lot of things we're going to draw from this diagram over here, because we have to recognize that each patient is unique and have their own particulars. There's no two diabetic patient that is alike, there's no two hypertension patient that is alike. But how do you drill down in a framework to understand where they are? So at Palo Medical Foundation, we look at it in terms of a motivation axis and a capability axis. Again, chronic care is relationship. We want to move away from a disease-centric way of looking at that. So we take a look at the patients. How motivated are they for them to take action on stuff? So we have a lot of work on motivational interviewing in our staff, in our teams, to engage patients in that space, because we believe I'll share with you some of our outcomes in terms of medication adherence. We have a lot of improvement work to do. When we look at our patients, by and large, our doc prescribe guideline-based medications, but the patient's not picking it up from the pharmacy. Why is that? Part of it is the motivation part. And I think part of the opportunity here that we have, and I'll share a little bit later, is that how do we enlighten and engage patient why we're recommending the medications and treatments that we do, so that they accept it and take it and embrace it, and they're motivated to continue with that. So that's one part of it. The other part of it has to do with their capability of managing that. That gets a little bit of about looking at patients. That's where social determinants of health come in, their resources come in. And for our population here, the capability part is highly affected by what's happening around the external world around them. For instance, obviously we want patients in the top right corner, highly motivated, highly capable to take care of themselves. We recognize and we understand that this is dynamic. Today they're highly motivated and capable, but the next day something may happen and they become demotivated or they're not capable. Story that we have over there is that there's a great patient's highly motivated, capable, but suddenly their spouse becomes critically ill, and suddenly their priority has changed, and their attention is on someone else and not them. They stop taking care of themselves, taking their medications, and their health declines and all that. People go through life crises. They have loss of a job, for instance. So that we keep that in mind, recognizing that patients can move around anywhere of these quadrants, and the health system, like us, needs to be prepared to recognize that part of the patient and enable to then adjust the way how we engage them in the way where they are. And that's kind of critical, and I think that's part of what we try to build into our interventions as well. So I want to talk a little bit about moving towards how do we implement things. And some of this people recognize. We're going into a world that's team-based care. Part of the design process called into that. But in that team-based care, we do take a look at a pretty expansive view of that. The traditional way of how they look at team-based care is very physician office-centric. Do you have a allied health professional? Are there social workers? Are there nurses, etc.? That's all good. But then again, you all know, patient spends, if you're lucky, 0.1% of their time in the walls of your healthcare facility, because you don't really want them to spend a lot of time there. They're spending their time in their own world. So how do we connect patients with the team that can help them in that? So that's why when I talk with Hattie, when I talk about healthcare, about the RightCare initiative, it's great that we have these great health systems here. You know, UCSF here, Stanford's here, we're here, Kaiser is here as well. I think that there's so many silos in a way how we operate. We recognize that really the value, and this is what this team also represents here, is that there are other groups in the ecosystem that we should connect the patients to. We, Palo Medical Foundation, even we have a million lives, we don't have to do it all, nor should we, because our core competency is not developing an app. And frankly, although we have our own education programs, sometimes I wonder whether we should partner more with external groups to deliver health education to our patients, because our infrastructure is expensive for us to build it. While it may be good quality, we may be able to develop more value by partnering. So that's what we call out, we're connecting to patients, but I think really, and I think that's one of the things that we can do over here, is that how do we connect ourselves to each other to manage a population over here to leverage opportunities. And those of you who represent organizations that engages or works with or empower, educate patients, I think that's a great opportunity for us to learn. And then finally, on our conceptual framework of that, this goes back to my first slide about when we did this work. That was when Atul Gawande came out with a seminal article about hotspotting. It came out the month before we did this design work. So again, how do we hotspot the patients who are critical? We want to capture that's consume all the healthcare costs and all that. That was very resonating to us. However, when you look at a population level, really the work we really need to do is in blind spotting. Because again, back to what I talked about earlier, if you wait until they become hot spotting, you have lost all the opportunity to improve the health outcomes and lower the cost, because at that time it's too late. So part of our work here in our system is how do we capture the patients before they start on that journey. And when we thought about this work, going back to the crazy world that we're in, is that in a climate where there may not be direct compensation for that, what is the obligation of the health system to manage our population, to do it in a way that meets our objective for prevention of good health outcomes in a way that doesn't kind of make us bankrupt? Is a really real challenge that we have to think about. That's why part of what we do over here is doing some advocacy work, driving our system to go towards more value-based pay systems to do, and evolving those models over there. That's part of what our work is. At the end of the ground over here, my team, and I drive my team, is that regardless of all the barriers, you do what's right for the patient, and what's right for the patient is for them, to the extent they can, never ever have to have a stroke or a heart attack or an amputation or go on dialysis. So, with that in mind, then what my team does is really looking at what are the high priority patients that we want to focus on, and what is our implementation model to impact good outcomes, and how do we connect with the clinical delivery side of doing so. So our story, the next story, is going to be about the implementation part. And I bring up this slide because this is on my visual board, because we don't have all the answers. And I always tell my team, and Chhavi can say that, is that it doesn't matter we don't have everything in place. What I care about is that we start doing it, start trying it. Because again, failure versus making mistakes. It's okay to try something that didn't work because you learn from it. Then do it again. It is only by doing that you learn the most and can iterate the way to get to where they are. And some of the stories you're going to hear next is a result of multiple improvement cycles to get to where we are. And then, on the right side of the sickies, in my own handwriting, my group is tremendously guilty about this issue, is that we're not going to do anything until we figure every single scenario, have the perfect data before we do it, because, by golly, we don't want to harm a patient in this journey as part of their concern. Again, however, you wait for perfection, it's never going to happen. And again, the difference to me between success and failure in this space is in the implementation part. Because as you sit there and wait for perfection, your patients are not benefiting from your work, and they are getting harm along the way. So to me, that urgency to do something is key. And you're going to hear a little bit about things as we go on the implementation part. So I want to pause over here. That's part one of our story, because at the end of the day, what I want to share with you, okay, there should be another slide here about that is kind of our culture piece of that. And then when you drive that, let me talk about this. I'll take part one into questions. So what is our implementation approach? This is a slide, a framework that I use for my team. It comes from Donna Bidian's model of quality of care that you may have heard, where they look at quality in 3 pillars: the structure, the process, and the outcomes. And I like it because in a very simplistic level, how you want to impact patient outcomes, you need those 3 components to be in place. So for Palo Alto Medical Foundation, it starts with the people inside. We're very pleased to be recognized as one of the best places to work. And we really value and invest in our people and training them and engaging their work, explaining the why. So this is just a picture of my team, the quality team that does a lot of work. That's kind of where it starts. Great people can only do so much. You need to support them with infrastructure and tools. So part of our approach is also looking at how do we, again, in this story over here, looking at how are we impacting this population? How do we bring visibility to who they are? We have 1 million patients, so who are the ones we have to focus on for stroke and heart attack prevention? How do we segment them? And then based on that, how do we outreach to them, who needs to come into our care clinics, who do you link them up with, how well they're doing. That gets into the infrastructure piece. Some of it is bricks and mortar, a lot of it is the data piece of that. So our teams, a lot of it is investing on to ensure that we have the proper population health management tools to impact our patients. And then we do a lot of process mapping. You'll see that as a theme as we go through the implementation part. Because at the end of the day, we have two customers here. One is the patient, one is the clinical team to do these things. And then if you're not clear what the pathway it is, and you don't make the right thing to do the easiest, you're going to end up some optimal outcomes, and you're not going to get to where you want to go. So we spend a lot of time looking at the processes. Again, this is a little bit about lean methodology, how we do these things. And then my team is at what may be right this year may not be the right way to do it next year. So part of it is the improvement knowledge and revisiting your workflows and your process things. And as new information comes in, so you get feedback from clinicians that do it, from the patients that get touched by it, you iterate and you change and you adjust that. And then finally for us, we do also spend time to also recognize how we track our outcomes. Because excitement gets you a lot of energy, but at the end of the day, it's the implementation part, and also finding ways to know where you are in your processes and how you manage your patients. So this gets into our tracking system and how to catch that. And again, when you have 1 million patients spread across 39 care centers, some of them are just 2 docs, some of them are 200 docs, the complexity of how you operationalize something like that, without a good monitoring system, it's critical about that. Without that, it's hard to know where you need to spend your energy and where you're going to deep dive into capturing of areas that need your help.
Before you move slides, can you just describe that a little bit more?
Okay, so this one, I mean, this is just an illustrative example over here. One of the interventions that we have about blood pressure checks is when the patient comes into our clinic. Our RMAs are trained standardly to do a blood pressure. Sit down for 5 minutes, arm rested at a heart level, feet on the ground, take your blood pressure. What we recognize that what we wanted to do is that for a patient whose blood pressure is high, they should recheck a blood pressure a second time. That's guideline based on that. And then with the new recommendations there, you can recheck the blood pressure within the first 1 or 2 minutes. In the old days, because you had to wait for 5 minutes, that was that did not integrate with the workflow well, and very few patients, very few staff were persistent in doing so. So when the new guideline came in, we integrated it into our workflows and our rooming guidelines. And then now the standard expectation is that if a patient comes into your clinic and if the first blood pressure is high, we expect a second blood pressure check to be taken within the first 2 minutes and to document it in our electronic medical record. So what this is showing is the variation across sites of that adherence to that standard. And we use this to identify, oh, we should go to that low blue bar at the end and go see why. Is it a training issue, adherence issue, attention issue, or whatnot? Again, these things are not expected to be 100%, as we know. But again, if there's one side that can get above 80%, and another side's only at 20%, the question is, yeah, we have to go see and ask why.
Is this by team, or by physician, or by center?
Well, it has all of it. So we start at the foundation level, and it drills down to based on org chart, and it goes all the way down to the care center, down to the physician level. So we have it all in place.
And do you do unblinded data for the physicians?
For this work, the data is always unblinded internally. Yes, so it's completely unblinded. Very good question. Okay. So in essence, that's our culture. We value the people. We're very, very hard on our processes. And we're very deliberate and strategic in knowing what outcomes we want to look for. We use a chronic care framework we do, and we do recognize that patients' journey about this do travel along motivation capabilities. And we always try to keep going back to that when we don't get the outcomes we want. Go back to that so we can understand, do we have a system issue that we look at, or there's a patient particular issue that we need to recognize and to adjust. So that's a little bit of our framework over here. Now I want to kind of pause here, because that's the frameworks, and then we're going to talk about 2 implementation examples. But I thought I want to pause here and see if anybody has any questions on that. Cool. Well, on that note, then let's move into the next section over here. Let me tee it up a little. Oh, I forgot. How could I forget about this? I had to put this slide in here about our culture and the outcomes and the recognitions we have. The first time I met Hattie was at this event, where Hattie's team recognized my group for being a top performer in outcomes for diabetes and high blood pressure. Again, I just want to thank Hattie for that recognition and the collaboration with that. And I mentioned that also because I feel that culture piece that I just explained to you is also one of the results that generates some of the outcomes that we have. We're usually rated either 4 or top 4 or 5 stars on any quality measurement you have. This one's from Medicare. This one is more from the commercial cap data business. Actually, those are the charts I think you draw from. That's inside of the packet as well. So we have some external data to support that our approach is successful. And then this is my transition slide here. And one of the things that we are successful is that I recognize that we can't do this alone. So part of what we do is to leverage other partners to draw attention to this. So this is from the American Medical Group Foundation's work, AMGA's. They had an initiative called Together to Goal. This one is about improving optimizing diabetes outcomes for our patient, which is a major risk factor for heart attack and strokes. What I mention this too here is to remind us why I value forums like these, because part of the struggles we have in my medical group, and when you talk to my clinicians particularly, and I'm talking from a primary care perspective, they have so many competing opportunities at their face. They don't have the luxury as a specialist that the patient comes in for one defined condition. It's only the diabetes, only the stroke, or only the heart. They face the issue where anything under the roof does go to them. So while you're trying to do their cancer screening, screen them for diabetes, deal with their vaccines, while they're complaining to them about their stresses at work, and the divorce that he or she's having at home, and their inability to have time to spend time with their kids, and they have a rash you want to deal with. How do you find time to kind of address all the other elements that we need to do? So part of this is leveraging public awareness, the importance of that, because one of the challenges that we have is that the patients don't recognize that this is important for them. It is important to get screened for blood pressure, for diabetes, to know where you are, to know what your risk scores are for heart disease, because they don't feel it. By the time they feel it, it's too late. So part of you who are in public awareness things, I think that is something we want to partner and leverage with, because that is one of the opportunities that I think we can raise in terms of community awareness, so that we help proactively bring the patients in to come in to get the services that we need to do. We'll own the clinical assessment part and the treatment part, but we need help in the engagement part. Yes?
Under the Together to Goal campaign program, I know they have a plethora of resources.
Yes.
Did your team find a few pearls or resources that you liked under their campaign that was successful or helpful?
That will be in Chhavi's talk, that she will point out to that. So she will talk a little about that, but that's a great question. I appreciate that. Other questions before I turn it over to Chhavi? All right, Chhavi. So Chhavi's going to come up and tell you a little bit about our journey through diabetes treatment and our challenges that we see and some of the approaches that we plan to do to impact better outcomes in this space.
And then we're going to hear from Dr. Yu again about the heart program that they have.
And we're doing it on time.
Okay. Well, thank you for having me here. So I'll talk about how we take care of a diabetes patient at PAMF and how our system also is, the whole system is involved or revolves around taking care of the diabetes patient. Just also as a context, Together to Goal, Sutter and PAMF have been part of Together to Goal for the last, I think since 2016. When we first initially joined Together to Goal, the 3 planks that we picked up to work on were increasing referral to diabetes education, building some treatment algorithms, and also building an accountable care team for patients with diabetes. And this year, PAMF is participating in their bundle measure, where we are working on improving our composite bundle metric, which involves A1C control, blood pressure control, statin use, and nephropathy screening. So we have had to answer your question on we have used a lot of resources from AMGA, particularly their data analytics team has been really helpful, and they have helped us a lot in looking at our data and drawing conclusions from that. So to start off with, I'll just draw your attention to the recent economic cost of diabetes that was in the March 2018 edition of the American Diabetes Association, and we can see that how the cost has increased so much that the care of the economic burden of diabetes from year to year. So the most recent data they have is for the year 2017, where the total cost of care for diabetes patients is about more than 300 billion, with more than 200 in direct medical care and 90 billion in reduced productivity. So about 1 in 4 healthcare dollars being spent on diabetes patients. And if we talk about the per capita expenditure, it's about $16,000 per year for a diabetes patient, as opposed to $4,200 for a patient with non-diabetes. So huge cost. So definitely prevention, what Ed talked about, but what I'm going to talk about is what we do when a patient is diagnosed with diabetes and is in our care circle. So to give you a little bit of idea about what is the diabetes burden at PAMF. So at PAMF, we have about 25,000 patients who have a diagnosis of type 2 diabetes, and which accounts for a prevalence rate of about 10%, which is not that high as compared to if we look at other geographic areas of Sutter, where the prevalence can go up to as high as 16%. So we are okay in that, we're sort of like kind of average prevalence for diabetes. And if we look at the control rates for diabetes, and you have those numbers in your packets, we do fairly well. Our A1C control rates, which is A1C less than 8, is about 70%. But we also do a lot of internal analysis on that data. Like we look at how many percentage of our patients are who have had high A1Cs for, let's say, the past year, and they have not been escalated as in accordance with the recent treatment guidelines, or they have been kind of had a doctor's visit and they were given the proper recommendations on which medication to add, but they just haven't been motivated enough to follow that recommendation. So we do that internal data for ourselves and follow these patients. So if we want to look at, I would just describe our care at PAMF as a cycle where the different teams are sort of interacting with each other and interconnected with each other. So if we want to start with our patients who haven't had an appointment with a physician in the system, so those patients are the ones which our population health team or the quality team is involved with, because we have EPIC registries and databases through which we can pull up the list of patients who have, for example, had high A1Cs and have not had an appointment within the system, or they haven't been coming in. So we can take care of the patients at that level. There's a lot of pre-work that happens before the visit, and I'll go into a little bit of detail on that what is the kind of work we do to prepare for a diabetes visit. And then at the time of the visit, these patients are being taken care of extended care team. That's the theme, that we have a team-based visit for diabetes with involvement of diabetes educators, pharmacists, referral to podiatrists, endocrinology. And then these patients are again connected back because of dashboards, and we have physician level reports that we generate monthly or quarterly, and that complete sort of the cycle, because if some of the patients who have been dropped out of the care cycle, they can be picked up by our data analytics team or the quality team, and they can be kind of brought back into the care circle.